I'm super excited to have you here for our Implementation Science seminar series. We are thrilled to have Dr. Chris Miller from Harvard Medical School and the VA. And Natalie has worked with Chris, so she is going to introduce him.
Chris, thank you so much for joining us. It's a pleasure for us to have you here. So Chris Miller is an investigator and clinical psychologist at the VA Boston Healthcare System Center for Healthcare Organization and Implementation Research prior. He's also an associate professor of psychology at the Harvard Medical School Department of Psychiatry. His research focuses on the implementation of team-based collaborative approaches to delivering outpatient mental health care, and we've worked a little bit together. So looking forward to your talk, Dr. Miller. Thank you for joining us.
Thank you so much. I appreciate it. Hope people can hear me okay. So I've got my title slide here. Thank you for that wonderful introduction and for inviting me. So as you can see, and I think as Natalie previewed here, I'll be talking about developing and really sustaining a team-based collaborative model of outpatient mental health care. I've got my affiliations here. When it comes to kind of the outline here, I'll start with acknowledgements and then go on and talk a little bit about kind of what we called our original BHIP CCM Enhancement Project 1.0. I will talk about kind of the context for that study, as well as kind of the primary study results and sustainability analyses that followed kind of in the years immediately after the trial was completed. We'll then talk about current kind of ongoing work, or the BHIP CCM Enhancement Project 2.0, with a focus on the adaptations to our implementation facilitation approach, as well as preliminary findings, because we are kind of in process right now, but just kind of wrapped up essentially the primary facilitation endpoint for one of our waves, which I'll get to more details on that. Finally, I'll talk about next steps for analysis and application, as well as then some conclusions and implications. And again, hopefully leave kind of some robust time for discussion. I have the chat window up, but I won't be necessarily attending to it directly, at least during the talk, but I'll try to kind of peek over there occasionally. All right, so in terms of acknowledgements, funding from this comes from a couple of different iterations of the Behavioral Health Query Program, or Quality Enhancement Research Initiative. This is basically a VA mechanism that's similar to kind of the NIH Alacrity Centers. So really kind of happy to have that funding, as well as a little bit of in-kind funding from VA's Office of Mental Health and Suicide Prevention, or OMHSP. That's not a research arm, but is kind of the clinical arm in VA that at the VA central office level kind of oversees, well, as the name implies, mental health and suicide prevention efforts. I don't have any conflicts of interest to declare. As you might expect, if I wanted to make money off of my research, then going into kind of establishing mental health teams in VA probably wasn't the best way to go. Having said that, the views I'm presenting here are my own. Please don't take this to represent the query program, the VA, the US government, or anything like that. I will note up front as well that we got the appropriate approvals, thankfully, for all project activities. Some of this was done under research and was overseen by VA Central IRB. Some of it was deemed quality improvement, and so wasn't subject to IRB review. And I want to acknowledge, of course, there are many co-authors. The original behavioral health query, I was a co-investigator. I took over as one of the co-PIs for the current iteration of the behavioral health query program. So this work is definitely not my own solely, and I want to kind of acknowledge that up front. So with that in mind, kind of moving on here to talk about the first iteration of the BHIP CCM Enhancement Project. So this is kind of a mouthful of an acronym, but BHIP, or the BHIP teams are, as it says here, Behavioral Health Interdisciplinary Program Teams. And as you can see, they're really meant to be kind of the nexus for delivery of team-based general outpatient mental health care within VA, right? These BHIP teams are originally launched at some pilot sites back in 2014 by the Office of Mental Health and Suicide Prevention. And you can see on the right-hand side here that the original kind of undergirding was these three pillars of collaborative, veteran-centered, and coordinated. So basically, the teams also came with an evidence-based staffing model. Basically, the suggestion at this point is that a team should treat a panel of about 1,000 veterans, again, for outpatient general mental health care, and should consist of about 9 interdisciplinary full-time staff, including, for example, 8 clinicians and maybe 1 care coordinator. So interdisciplinary meaning typically a mixture of psychiatrists, psychologists, social workers, other prescribing clinicians like APRNs or clinical nurse specialists. Could also include things like peer support, front desk staff in a non-clinical role, that kind of thing. All right, so the establishment of these teams is really what this is all about. But it kind of raises the question, above and beyond these three general pillars of collaborative, veteran-centered, and coordinated, how do we want to actually structure and establish and guide the work of these teams? And that's where the CCM comes in, right? So for those who aren't familiar, the CCM, Collaborative Chronic Care Model, originally conceptualized as the chronic care model, but kind of with some patient input, really wanted to emphasize more collaborative rather than chronic, in at least the title here. But as it says, it's kind of an evidence-based way to structure care for chronic conditions. And the overall goals of CCM-based care, very consistent with those pillars we saw before for BHIP-based care, namely more continuous, collaborative, evidence-based, and anticipatory care. And really the heart of the CCM are kind of 6 core elements or principles, which you see here. So the basic idea here is that the CCM, again, is an overarching way to structure care for long-term health conditions, rather than one specific workbook or evidence-based psychotherapy manual or medication algorithm or anything like that. So how this kind of manifests, at least in VA, we've got this BHIP CCM enhancement guide. It kind of spells out how to establish BHIP teams consistent with the collaborative chronic care model. But you can see the 6 elements reflected here, right? So CCM element 1, organizational leadership and support. You see that's along the bottom because that, of course, undergirds everything else, right? The basic idea here is that if you're trying to implement kind of CCM-based BHIP teams, you really need to have leadership support upfront, or of course, it's going to fall apart as soon as competing priorities come into play, staffing shortages occur, that kind of thing. CCM element 1, so on the left-hand column here, work role redesign, otherwise known as delivery system redesign, is really just about kind of shifting work roles around to support this more kind of anticipatory and continuous care, right? So maybe you've got a care manager role or a care coordinator role, who can kind of follow up with patients between sessions, be kind of responsible for doing kind of same day access for non-urgent issues, following up with people who may have fallen out of care, that kind of thing. Element, in this case, kind of element 3 is really the second column, veteran self-management support, is really about making sure that veterans or patients have access to the resources they need to work toward wellness between sessions, right? If our veterans are only thinking about their mental health when they're face-to-face with a clinician or in a video call with a clinician, then they're really missing out on a lot of opportunities to kind of improve their health, improve their mental health between sessions. You can see provider decision support is really about making sure that clinicians have access to the expertise they need, right? So this may take the form of accessible practice guidelines for delivering their own care. If it's something that's beyond their area of expertise, making sure they've got access to specialty consultation. And if it's something that needs to really be delivered outside of the context of their own clinic, making sure that referral processes to send veterans out of the BHIP, at least temporarily, is streamlined and well understood. The kind of penultimate CCM element here, information management, is really about encouraging kind of a panel-based approach to care, right? Trying to create these BHIP teams in such a way that they see themselves as responsible collectively for a set of veterans, rather than simply, I'm responsible for my own personal panel, and I just happen to attend a team meeting, right? So this can take the form of kind of feedback on evidence-based care delivery, feedback on quality of care, and importantly, maintaining some kind of registry or panel of the set of veterans for whom each individual BHIP team is responsible, right? Finally, community linkages acknowledges that really to deliver good care, we sometimes need to go outside the medical center entirely, right? So finding ways to systematically connect to things like AA and NA groups, peer support, or other community resources. These collectively constitute the 6 elements of the CCM. So again, I want to emphasize, this is not kind of a one-size-fits-all kind of approach. These are really a set of principles or elements to consider and build into care to make it more, again, anticipatory, continuous, evidence-based, and collaborative. So what we've got here then is the context of, we've got a BHIP rollout in need of a guiding clinical model, right? We've got state of the science, good evidence for the CCM as a way to structure care for chronic conditions, including chronic mental health conditions, but few implementation trials. And this led to the CCM being formally adopted by OMHSP as the guiding clinical model for BHIP. as well as the launch of the BHIP CCM Enhancement Project, which was basically an attempt to help 9 BHIP teams, one at each of 9 VA medical centers, adopt more collaborative care practices for their BHIP teams. So how do we do this? Well, we basically had a hybrid type 2 stepped wedge. You can see here that the kind of map or picture of kind of how the trial was set up, and I'll go through the components kind of individually here. So again, we had 9 sites. So basically take this figure and multiply it by 3 to get the facilitation timeline for each of the 9 sites, right? And so what you can see is that all participants, each of the sites, the BHIP team clinicians received 1 year of facilitation support from an external facilitator. You can see we split it into 6 months of kind of very active facilitation, followed by 6 months of step down. The kind of stars and dots represent kind of starting and ending points, as well as data collection points to see how we're doing. And the minus Q4, Q3, Q2, and Q1 shows that for each of the veterans treated by these BHIP teams, we look back 1 year for things like clinical covariates, hospitalizations, that kind of thing. The start time was randomized. So for each of the 9 sites, we basically assigned them to wave 1, wave 2, or wave 3. While we say randomized here, we did also use a balancing algorithm to make sure that while we were kind of quasi-randomizing sites to waves, we made sure that the waves were balanced. We had a couple of different types of control or comparison built in, right? One, we will acknowledge that the later wave sites got technical assistance while they were awaiting facilitation support, but also acknowledge that for our comparison veterans, we looked at other veterans at these same medical centers who received their mental health treatment at other GMH clinics or other GMH clinicians who weren't taking part in the facilitation. So what the facilitation really consisted of was an external facilitator, myself or 2 colleagues, working with an internal facilitator and 1 BHIP team at each of these sites over the course of the year, right? We used what I referenced briefly before, the BHIP CCM Enhancement Guide, to really help walk that internal facilitator and the BHIP team through kind of the elements of the CCM, having them kind of take a close look at their clinical processes and decide, hey, when it comes to things like intakes into the clinic, step down to lower levels of care, how care is delivered when a veteran's being treated within the BHIP team, are we kind of adhering to those elements of the CCM? And if not, doing some small tests of change, doing some kind of continuous quality improvement, essentially, to help align their care processes more fully with those elements of the CCM, right? So the goal was that by the end of the year of facilitation support, these BHIP teams would be delivering the care in a manner that was consistent with those CCM elements or principles, right? So
Chris, there was one question someone had written me in the chat, which I don't think you can see, about, is this regardless of diagnosis? They were wondering.
Good question. So the BHIP teams and general mental health care within VA more broadly is meant to be the kind of the catch-all basic level of outpatient mental health support. So that means they kind of deal with the grab bag of patients. Now, at most medical centers, there's separate specialty care for substance use as well as PTSD. But not surprisingly, a large proportion of the veterans treated by these BHIP teams also had maybe a comorbid substance use disorder, maybe have PTSD as one of their diagnoses. So for our purposes here, the only veterans that we removed from the analyses were those with dementia or other kind of situations like that where we think that there might be real cognitive impairment. But otherwise, this is relatively broad-based. And we were looking at kind of naturalistically veterans treated by these BHIP teams. Does that answer the question? Any follow-ups to that? Thank you for jumping in. Again, feel free to jump in with clarifying questions throughout this portion as well. But moving on here. Okay, so our overall hypothesis, right? It was kind of I mentioned this was a hybrid 2. And that means that we were kind of equally interested in kind of implementation outcomes and clinical outcomes. So our kind of overall hypothesis here was that this implementation facilitation would lead to what we call improved CCMness, right? Improved kind of collaboration within the team, as well as improved clinical outcomes. So we looked at things like veteran health status and perceptions of care. We looked at provider perceptions of kind of CCMness through a couple of different measures, as well as administrative metrics of quality. So I'm going to focus on here, right? Briefly, when it comes to veteran health status, we use the mental component score of the VR-12, which is basically a veteran's version of the SF-12, kind of health-related quality of life metric. We also looked at mental health hospitalizations. When it comes to provider perceptions, we looked at outcomes of the team development measure, which, while not directly focused on the CCM, essentially gets at the kind of teamwork things we'd expect to see for teams whose care practices do align with those CCM elements. We also had process counts from the BEEP CCM Enhancement Guide, as well as qualitative interview data. Now, I'm not going to exhaustively review all of the outcomes, but focus on just a few things, some of which are listed here and some of which were kind of spin-off analyses. Namely, when we looked at outcomes from the BEEP CCM Enhancement Project 1.0, we did see on the team development measure improvements in role clarity and collective team goals, or kind of a domain we call team primacy. So that's basically the extent to which these clinicians feel like they're working toward the clinical goals of the team, again, rather than simply delivering care to their own panel of patients while maybe happening to sit in on a team meeting. We also found a pretty big reduction in mental health hospitalizations for veterans treated by these teams. This was connected to a 25% reduction in all-cause mortality, from what we could tell, and then substantial cost savings, where basically for every dollar spent on implementing these more collaborative teams, we saw savings of about $1.70 that same year, based primarily on the reductions in very expensive, costly, disruptive mental health hospitalizations. So a little bit more detail on this. On the left-hand side, we see the team development measure results. This is basically for the clinicians on the BEEP teams with which we worked. What did we see in terms of 4 domains of the team development measure? Basically, long story short, when it comes to cohesion and communication, namely how well these clinicians got along with one another and communicated with one another, we saw what we think is kind of a ceiling effect, kind of levels of agreement, so agree or strongly agree responses in these domains were kind of above 80% to begin with and didn't really move very much. But we did see statistically significant improvement in kind of role clarity and team primacy. So the extent to which people understood their role and the role of their colleagues on the BEEP team, as well as the extent to which, again, folks were working toward shared goals as a team. The hospitalization data on the right-hand side, I'll just unpack this a little bit. You can see that the anchor point here in the middle is the pre-Q1 time. So what's shown here is the mental health hospitalization rate by quarter. You can see that the one line here is veterans treated by what we call these CCM enhanced teams, as compared to other clinicians at the same, or other veterans treated by other clinicians at these same medical centers for outpatient mental health care who didn't undergo this facilitation. And you can see that in the year prior to implementation, right, the pre-Q4 through pre-Q1, relatively similar rates of hospitalizations. But over time, following the start of implementation, thankfully, outpatient mental health care helps, right? The mental health hospitalization rate for all of these teams dropped, but it dropped more precipitously for the veterans treated by the teams with which we were working, right? So this is certainly a good sign. When it comes to all-cause mortality, this is kind of the unadjusted figure on the left, although the estimated reduction in all-cause mortality held up when we included a bunch of covariates. You can see the kind of divergence of the lines over the course of the year of facilitation, with the CCM enhanced teams, veterans, having a lower risk of death over time. And then when it comes to the cost analyses, we did some Monte Carlo simulations based on things like cost data for hospitalizations, staff time spent doing the implementation. And you can see that in most of the kind of analyses, most of the simulation modeling, we see that CCM-based care appears to be likely cost saving or at worst cost neutral, right? So kind of combining these all together, this felt like a good set of results, right? We've got improvements in team functioning based on the TDM. We've got some promising improvements when it comes to mental health hospitalization rate. We've got apparently a reduction in all-cause mortality, especially when comparing these veterans treated by the teams we worked with to veterans treated by other teams at the same medical centers.
Chris, there's a couple more questions I was just going to flag.
Yep.
One
Yes.
is, were patients with diseases such as COPD included who have a high risk of anxiety and depression?
Yeah, absolutely. I mean, for many of our veterans, right, treated in these outpatient general mental health teams, of course, there's a lot of comorbid physical health conditions, right? So we would certainly hope that those conditions would be relatively evenly distributed between the veterans treated by our teams versus the veterans treated by other teams in the same medical centers. And while I didn't present those data here, we did see a relative balance. We looked at a whole bunch of different covariates to make sure that the veterans we were comparing were not kind of systematically different at baseline. And any selection bias for those who did not participate in CCM, what kind of patients were those? Certainly there's possible bias there when it comes to, okay, just to kind of emphasize, right? We worked with one BHIP team per medical center, and we compared veterans treated by that team with which we worked at each medical center to other veterans treated within other teams or other GMH clinicians at the same medical centers. So it's certainly possible that there might be bias if the reason that the BHIP teams were chosen for us to work with is because they were already really high performing, then that might, of course, introduce bias. But to counteract that, we really tried to emphasize working with a team that's neither already doing great nor kind of fundamentally really dealing with such fundamental challenges that they can't do any kind of process redesign. So our hope is that there's a relative balance here in the comparisons we're making here. Did you also look at professional team burnout and stress levels as an impact on care and team quality? We didn't have a quantitative measure of that, but our qualitative interviews certainly got into that. And thankfully, what we saw from the qualitative interviews is that first, overall, not surprisingly, there is a certain level of stress that comes with engaging in this kind of team building exercise, working with an external facilitator for a year, not just working on treating our patients, but trying to align our care processes with the CCM takes time and effort, and I don't want to downplay that. What we saw from the qualitative data is that people really seem to appreciate working more collaboratively with their fellow BHIP team members, right? We heard things in the qualitative interviews like, this really gives us a nice forum to discuss the patients who otherwise keep us up at night. I feel like I'm not alone in delivering care to an otherwise very challenging set of patients. So while we, again, don't have necessarily a ton of quantitative data on burnout and stress, certainly if the qualitative data are to be believed, this may have actually helped with those things, or at the very least didn't hurt. Okay, so that was BHIP CCM 1.0, and I'm happy to provide the specific articles here from the outcomes, including the primary clinical outcomes, the mortality findings, and really anything else related to this if you'd like. But the flip side of this, right, the kind of dark underbelly here is, unfortunately, when we looked afterwards, did kind of repeated many of our quantitative analyses a year after facilitation ended. We really didn't see any evidence that these gains had been sustained. Basically, the veterans treated by our kind of BHIP CCM enhanced teams and veterans treated by other teams or other GMH clinicians within the same medical centers didn't look all that different 1 year after we stopped facilitation. And when we did some qualitative interviews further down the road, 3 to 4 years after we'd wrapped up, we found that many of our sites, many of the 9 sites, essentially seemed to have returned to business as usual, right? So in a few cases, not the majority, thankfully, these BHIP teams had been disbanded entirely, right? If there was a team that had like 6 to 8 clinicians and 3 of them left the team or retired within a 3-month span, oftentimes that team ceased to really function as a team, or maybe just stayed on some org chart somewhere. But these folks are basically delivering kind of siloed individual mental health care instead of really being a team. At other sites, the team stayed intact, right? The teams are still meeting together. They're maybe still discussing cases or discussing intakes on a weekly basis. But the more robust collaborative care components kind of fell away, right? So emphasis on veteran self-management support, emphasis on streamlining referral processes, tracking how we are doing as a team based on a panel of patients that are our collective responsibility. At many sites, those things seem to have fallen away, right? And so this led to the impetus for the BHIP CCM Enhancement Project 2.0, right? So basically, we wanted to kind of do a similar trial, but we wanted to modify our implementation approach to make this more sustainable, to see if we could get similar clinical outcomes that wouldn't disappear 1 to 4 years after we stopped facilitation support. And so based on kind of the qualitative interview data and some follow-up analyses and talking with our operational partners, we basically came up with 4 ways to modify this kind of external or implementation facilitation approach to hopefully enhance sustainability. So first row here, as I mentioned before, we were working with 1 BHIP team per medical center for the BHIP CCM Enhancement Project 1.0. But a challenge with that is that, well, many changes were really outside the scope of any one BHIP team. When it comes to things like clinic intake procedures or discharge procedures, it's not up to any one clinical team within a clinic. It's really up to clinic leadership, right? So it was really frustrating for teams if they knew that there was a challenge they were facing. They knew what steps might be helpful, but they didn't really have the power to make those changes. Another challenge here is that working with just 1 BHIP team per medical center, of course, limited the scope of the change, right? If you've got a medical center that's got 50 mental health staff in their general mental health clinic, then just implementing CCM-based care with one set of 8 to 10 of those clinicians, it's really kind of missing the goal, right? So what we did for BHIP CCM 2.0 is we're instead having an external facilitator working with a BHIP CCM implementation team that's really looking to kind of put these BHIP teams into place with these collaborative care components across the entire general mental health clinic. So really expanding the scope within each medical center. A second issue is that in BHIP CCM 1.0, the external facilitator, the external person, was really seen as the primary driver of the implementation process. But what we saw is that what that meant is that after the external person left and facilitation support wrapped up, not surprisingly, kind of the impetus or motivation to continue these collaborative care pieces really kind of fell away, right? With a few exceptions at sites that really had a strong endogenous push to have collaborative BHIP teams. So for this kind of next iteration of the BHIP CCM Enhancement Project, we've really shifted the locus of control more firmly to the internal facilitator and that local BHIP CCM implementation team, right? We're really trying to frame this as we are helping you with a process that you have decided is important and that you are driving. And hopefully that means that once the external facilitator leaves, the kind of collaborative approach to care doesn't leave with them. The third of 4 kind of changes we made, well, acknowledging that in BHIP CCM 1.0, we basically had a year of facilitation, 6 months of active support, 6 months of step down. But we really saw that most of the changes happened in that first 6 months. The latter 6 months didn't really feature a whole lot of change. And so for BHIP CCM 2.0, we're shortening our implementation period to 8 months, but really trying to maintain consistent effort throughout. So we hope that this is basically kind of shrinking the facilitation period without necessarily shrinking the amount of attention being paid to the implementation itself. And finally here, the initial BHIP CCM 1.0, we had a kickoff site visit that was in person. It was 1.5 days with each team or at each medical center, a half a day of which was specifically with each BHIP team in question. But based on factors that you folks probably don't need me to spell out, thinking about things like travel costs and the pandemic, we instead shifted that to a virtual kickoff period. So again, still trying to do our kind of laying good groundwork, working with the site, getting to know the staff and all that kind of stuff, but doing it in the context of virtual meetings rather than kind of an expensive and concentrated in-person site visit. So again, just to summarize these past 2 slides, this is how we didn't necessarily change our approach to kind of collaborative care or BHIP teams, but how we changed our implementation approach to try to make these BHIP teams more sustainable at the 8 sites with which we're working now. So the kind of current status here, again, we've got a stepped wedge. So we're working with 8 sites over 4 waves, and we began this past summer. The waves are spaced about 2.5 months apart. We just wrapped up the implementation period for wave 1, and we're in kind of the midst of implementation, that 8-month period for each of waves 2 through 4. So we don't have data or outcome data for the study at this point, not for BHIP CCM 2.0. What we do have, though, is just some preliminary findings from wave 1. So this is, again, from the team development measure, just the findings from the first wave. So I'm not presenting statistical significance here because we wouldn't really be powered to find that anyway. But we see, I think, some promising results, right? Cohesiveness and communication, looking kind of pre-implementation to post-implementation. Numbers were kind of high throughout. Again, we've got a bit of a ceiling effect for these two domains of the TDM, because if you're at 90+% before you start implementation, you wouldn't necessarily expect to see that move. But we did see at least some modest improvements in role clarity and team primacy. Again, the extent to which people understand one another's roles in the BHIP team, as well as the extent to which they feel like they're really working as a team towards shared goals. So certainly if this is borne out with the other waves, we hope that this will be good evidence of kind of improved teamwork based on our implementation. There's a question here, do we have evidence comparing effectiveness of on-site versus virtual facilitation? So from this trial, not yet, because we're still working on that. I will say that within VA, there's an implementation facilitation, basically training hub. And they've been doing a lot of work, I think, demonstrating that, you can accomplish many of the goals of facilitation virtually. That's just the world we live in now. And I want to emphasize that with BHIP CCM 1.0, other than the site visit, everything else was virtual for the facilitation year. So really the only thing that's changed here is how we're doing the kickoff meeting of the site visit, rather than kind of the bread and butter of week-to-week facilitation support. But again, I wanted to pause here. Other questions at this point? How are you promoting ownership and also feelings of competence in the internal facilitators for 2.0, and how is that going? It's a great question. I could talk for the rest of the time just about that. So we knew up front, right, that if this was seen as a process that was driven by, quote, the external consultants, unquote, that would probably fall apart as soon as we left, right? These frontline folks are under incredible workload pressures. Mental health leadership has a lot of different competing priorities related to suicide prevention, access, getting veterans into care, delivering evidence-based practices, all that kind of stuff. So we really tried to do kind of a full court press on ensuring local ownership. So starting with the program letter of agreement that kind of documented how we're going to work with the sites. We said really clearly in plain language, we are helping you with a process you are taking ownership of. We need you to name an internal facilitator. We need leadership to sign off on the fact that the internal facilitator will be the one driving the process. While we're not asking for specific funding support or like any of that kind of pieces, we do want assurances that the internal facilitator has at least 4 hours per week to dedicate specifically to this implementation. We need you to name a local BHIP implementation team who's going to work with the internal facilitator. We want to make sure that that BHIP implementation team has representation from key groups like individual BHIP teams, psychiatry leadership, other mental health leadership, that kind of thing. And then throughout facilitation, really just as an external facilitator, a lot of what I am doing is talking to the internal facilitator about, hey, I can provide, connections to resources. I can help provide guidance, but I can't be the one writing up the meeting notes. I can't be the one emailing your local staff about, how the team meetings are going or anything like that. So we've really tried as external facilitators to really take a step back, and really baked into the facilitation right now is empowering the internal facilitator and the implementation team, making sure that we're communicating with leadership or they're communicating with leadership about the importance of this initiative, that kind of thing. I hope that helps. I'm going to keep going through the questions here because I'm almost through with kind of the structured part of the presentation anyway. Okay, for intervention sustainability, are clinicians rewarded for their team efforts through annual reviews and salary? That's a great question. This might be a situation where, as an external facilitator, external to the medical center, I certainly don't personally have power over those things. When I think about annual reviews and salary, that's probably something we should think about building in. Right now, I think a lot of the benefit to the frontline clinicians is that they feel like they're working better as a team and they have the support of the people around them in doing their work more collaboratively. But to date, no, our implementation approach has not involved those things. But that would be a great thing to get our local BHIP implementation teams to consider adding. Next question here. Some posit that sustainability requires not just ongoing QI and learning, but also adaptation. Any thoughts on CCM adaptation needed for sustainability? Another great question. I think that the kind of blessing and the challenge about CCM-based care is that the CCM is so inherently flexible, right? So I'm not going to go back to kind of that slide of the CCM elements before, but because there are a set of kind of elements or principles, we don't necessarily think of this as adapting CCM-based care itself. But I will say that a ton of this work is really helping these sites work through and kind of seeing what the best way is to achieve those collaborative care elements, given the context and resources that they have. So while I can't point towards specific adaptations of the CCM at our sites, it really does to me seem like it's kind of baked into the narrative that they are kind of adapting and tweaking and refining their care processes. And I will say that a core part of the facilitation work is doing small tests of change, right? Tweaking the process, see what happens. So for example, a lot of the sites we're working with now are changing their intake processes to make sure that the right intakes are done at the right time. Veterans aren't having to tell their story 3, 4, 5 different times. When veterans are going to do an intake with someone, they know what it's about, so they don't no-show or show up and then leave frustrated. So I think that there's a lot of adaptation taking place kind of just through the course of facilitation. Okay, next question. How did you share the initial period 1.0 was apparently positive evidence-based results? I would have expected that clinical leadership would have continued their support and even expanded the approach. Yeah, that's a great question. So, I mean, I think part of this is a timing question, because of course, facilitation wraps up, right? We have our data. It takes several months to kind of do the analyses, especially qualitative analyses take some time. Then we kind of go and we write it up. We did let these sites know what we found, but I think at the sites where CCM-based care kind of fell away, by the time we're providing data, it was a little bit too late, frankly. And I will say that we currently have a spin-off project conducted by kind of essentially a quasi-CDA or career development awardee who is connected to the career program to figure out how best to feed back positive findings about CCM-based care to clinicians and veterans to hopefully get more buy-in. But I think that to a large extent, the challenge here is simply the delay between when you wrap up a project and when you actually have the results of that project. Okay, another question here. Might you see an internal facilitator as the champion, or would you consider both in the team? Yeah, a great question. I think at many sites had a separate BHIP champion and internal facilitator. At many sites, the internal facilitator was the BHIP champion. And I think part of what we're finding is that if the internal facilitator is not themselves a member of mental health leadership, then it's really important to have somebody from mental health leadership who is seen as a champion, who can kind of advocate for BHIP at higher levels of the medical center to make sure that this is still prioritized. Rachel asks about challenges to sustainability. Yes, attrition and turnover. So this is kind of ubiquitous at this point, I think, among mental health teams. I think that a lot of the benefit of working with a BHIP implementation team and multiple BHIP teams within the medical center is that hopefully attrition and turnover within one team doesn't kind of torpedo the whole process. But I'll admit that if I had the complete solution to how to do kind of change management and improve care processes in the context of really rapid turnover and workload pressures, I'd probably be making a lot more money than I'm making now, right? That really is the million-dollar question. And I think the best we can do is work closely with leadership, help feedback in real time what positive results we're seeing from this, and hope that that can continue to keep BHIP and collaborative care at the top of the agenda, even in the context of turnover and staffing pressures. Another question here, what are the essential skills and experience of the external facilitator for this approach? One of our formerly mentees, but now kind of one of our co-investigators, Dr. Sam Connolly, has actually published some papers specifically on the qualities of facilitators and kind of what it takes. I'll also note that Joanne Kirchner here within the VA really helped champion implementation facilitation. And there is a publicly available implementation facilitation manual that goes into a lot more detail about the qualities of an external facilitator. In broad strokes, though, I think what I would just say here, given the amount of time we have, is that an external facilitator ideally will have two broad categories of skills and knowledge. One is in kind of facilitation and change management, which involves everything from kind of working through systems redesign or change initiatives, but also addressing interpersonal issues and the challenges that come up when you've got a multidisciplinary team of people trying to work together in the context of kind of a stressful working environment, like so many mental health clinics are, right? But the other set of skills is really having some working knowledge of BHIP and mental health care. For at least this type of work, if you get an external facilitator who's a really good like systems analyst or process redesign champion, but doesn't know mental health, that can be a real handicap. All right, so that's, I think, maybe where I would leave that, at least for now. I'll keep going on here and then open up to broader questions here. So next steps, right? I've talked about preliminary results, but next steps, obviously we need to complete facilitation for waves 2 through 4. We'll be looking more closely at the primary outcomes for this trial of the team development measure as our implementation or team functioning outcome. Mental health hospitalizations is our primary kind of clinical outcome for this. We'll also have kind of additional secondary analyses looking at cost effectiveness as well as qualitative interview results. And then we've got built in kind of a sustainability analysis, redoing some of these things a year after facilitation ends at each of these sites to see whether we achieved our stated goal of not just having good clinical outcomes, but in some sense sustaining them or setting up these sites for success for after the external facilitator leaves. So conclusions, implications. I think we have solid evidence here that delivering outpatient general mental health care in a collaborative, team-based manner is better than kind of a traditional siloed approach where every clinician just kind of works with their panel and doesn't necessarily collaborate closely with their colleagues, right? We've seen from BHIP CCM 1.0 improved collaboration and clinical outcomes, but of course, implementation is a challenge. Getting this to stick and be sustained is even more of a challenge. And this ongoing trial really attempts to build on prior work, make key adaptations to how we're doing our facilitation that hopefully can, rely on local staff to kind of continue to carry the banner for collaborative BHIP teams, even after the separately funded external facilitator wraps up. And again, I think the preliminary TDM results are promising, but by no means conclusive, right? We need to see how it works at the other sites. We need to look at the mental health hospitalization data, all that kind of stuff. So at this point, I'll kind of pause here. Thank you all for your time and attention and questions throughout, but I'm also happy to open it up for broader questions at this point. I see here, is a behavioral sleep medicine clinician part of the interdisciplinary team? Great question. It really depends on the local context. I would say most BHIP teams don't necessarily have a BMed or behavioral medicine clinician specifically as part of the BHIP. I think that may be more likely to be a part of our integrated primary care mental health integration clinic. So for many veterans, they're seen in primary care. They may get a brief course of treatment in PCMHI and then get referred out to BHIP if PCMHI can't meet their needs. But for sites that don't have, as part of their BHIP team, a sleep medicine clinician, then we would probably think about, okay, how do you make sure that you can do good referrals or consults to a sleep medicine clinician? If there's nobody in the medical center who does that, how do we get leadership to consider prioritizing that hiring? Or how do we link to the community for that treatment resource? Those would be the kind of things we would work through consistent with this kind of collaborative approach to BHIP care.
This was fabulous. I learned so much and really appreciate how interactive you made and how you addressed everyone's questions. So thank you for your time. Have a great weekend, everyone. Hopefully